Many thanks for the opportunity to contribute to this trial session and to say a few words about observational research. So I'm going to cover these 4 points. First, it's not an either or. It's imperative that we utilise both observational and interventional designs when trying to improve patient care. The methods in the literature are moving quickly in observational research, and there are now a number of approaches to try and ensure that conclusions from those types of studies are robust. The classical RCT will have less of a role in the future, and I'll talk in detail about that. And I'll finish it by talking about the convergence of observational and interventional research, how this is essential and how it is a feature of many modern trial designs. I find myself dwelling more and more on causation, why things happen. This is a great book, The Book of Why by Judea Pearl, and I'd recommend it if you want to learn more about the science around causation. This is the ladder of causation, and we're trying to get to the top of it. At the bottom is association. What if I see questions? If I know that a patient drinks a lot of coffee, what does that tell me about their probability of a cardiac event? And it is association that machine learning and AI and the like are currently restricted to. Causal machine learning, for instance, only now being an emerging theme, which is why there's a robot sitting there. But it takes intervention in the environment to understand what if I do questions. We've got 2 young children, and they spend their existence physically and verbally testing assumptions about the world. Whether it's, will that window break if I throw my brother at it? Or will my father break if I tell him one more time I'm not getting in the bath? They are intervening on their environment in order to causally understand it all the time. And the power of intervening in a controlled situation, such as a trial, allows us to get an unbiased estimate of that causal effect, at least in the trial sample. If a random group don't drink coffee and another do, what will happen? But the top rung of the ladder is the hardest to get to. A counterfactual is a hypothetical reality that would have existed had something not happened. If I had drunk less coffee, would I have avoided this heart attack? And at a population level, the RCT provides an estimate of that counterfactual. But of course, for any individual, say in the treatment group, we do not know what would have happened had they not had the intervention. And RCTs are really not set up to understand variation and effect at the level of the individual. Of course, RCTs are seen as a gold standard, as something to aspire to. They are, of course, an incredibly important tool, but their special status is possibly unhelpful. They are, of course, very useful for identifying causal relationships, can reduce bias and confounding when examining those relationships, and are best at determining efficacy, at determining size of effect. But this is not without costs. Patients within a trial are often a convenience sample, may not reflect the target population from which they're drawn, and thus making generalizations difficult. Scaling up is difficult. Similarly, how the results of RCT apply to an individual patient is often misunderstood. There's this famous example from the American Medical Association's user guide to the medical literature, which stated, if the patient would have been enrolled in the study had she been there, that is, she meets all of the inclusion criteria and doesn't violate any of the exclusion criteria, there is little question that the results are applicable. I mean, in the era of precision medicine, this is just nonsense. The heterogeneity of treatment effect is often very large in studies and often very poorly understood. Said more simply, interventions often don't work the same for everybody. And while there are many benefits to RCTs, and I've run some and recruited to many, the design is at the expense of precision, efficiency, and scope. And that final word, scope, is really important. And in 2017, in the New England Journal of Medicine, Tom Frieden, who is now even more famous given his prominence, particularly on Twitter in the pandemic, said, "For much and perhaps most of modern medicine, RCT-based data are lacking and no RCT is being planned or is likely to be completed to provide evidence for action." And he coined the term the dark matter of clinical medicine. Observational studies and cohorts in particular can help us understand causation, and particularly causation over time. And I'll go on to speak about this. Selection and collider bias and problems with the representativeness of populations are a continuing problem with observational studies and will continue to be, as is trying to get to causation. But methods like instrumental variable analysis, Mendelian randomization, Bayesian networks, process tracing, etc., are all now increasing the robustness of the conclusions that can be drawn from non-interventional data. And we used some of these approaches in the Global Surge 3 study, mediation analysis and inverse probability of treatment weighting. I'm not going to talk about these in too much detail, but this was a global study looking at outcomes after breast, gastric, and colon cancer. And many of you will have contributed, and thank you for doing so. 16,000 patients across 82 countries, 428 hospitals, 120 variables, so really great depth of understanding of what patients were experiencing on going through surgery. And in one of the first analyses we did from this, we were looking specifically at what determines poor early outcomes after surgery, so poor 30-day mortality. And the cohort allowed us to look in detail about why some patients die after complications while others survive. So failure to rescue, or put in a more positive light, identifying the capacity to rescue patients. And the methods allowed quite a deep dissection of where the explanations may lie. 60% of the capacity to rescue being explained by patient or disease factors, but 40% being explained at the level of the hospital or the country or the income group. And a mediation analysis allows us an exploration of the relationships underlying an observed effect. And this was used to examine the influence of perioperative care facilities, dedicated recovery rooms, critical care facilities, the availability of postoperative imaging, and in particular CT scanning and the like. 20% of the effect of country income on mortality was explained by these post-operative care variables. And that was associated with 7 to 10 more deaths per 100 major complications in low and middle income countries. So, are these causal conclusions? Does the counterfactual I'm going on about hold? That is, had these facilities been available, would outcomes have been better? And of course, no, that is not the case. Post-op care is associated with many other causal factors, confounders. However, we do now have a much clearer understanding of those groups of variables, if you like, independent of those that were measured at the patient or at the disease level. We've been able to separate them out. But most importantly, rescue is a tangible opportunity for intervention. And that is where this research will go next. So I can't talk about cohort studies without COVID surge. I mean, it's a phenomenal achievement by our international community coming together to understand this disease in a surgical population, and is unprecedented, and the numbers of individuals involved are unprecedented. Patients early in the pandemic undergoing surgery with SARS-CoV-2 had a 24% mortality. Very important data demonstrating that risks were real and helping to guide policy internationally, real world data. And probably the most important COVID-19 study has been the recovery trial, the UK-based international study demonstrating the efficacy first of dexamethasone and subsequently of other interventions in the management of COVID. And so I'm going to finish off by trying to draw things together about where I think observational and interventional research are converging. So individuality, and that's patient individuality, is the enemy of the classical RCT, which would love if everybody behaved in exactly the same way in response to a treatment. And the days of the classical RCT measuring an average treatment effect across a convenience sample and drawing population level conclusions, these are drawing to a close. And as we understand more about the biology of the response to treatments, and by biology read causality, we must adapt our methodology to exploit it. So basket trials are now common. Many of you will be contributing, I'm sure. Multiple cancer types, screening for a particular biomarker with a drug lined up to be directed towards it, or an umbrella trial, a narrower group of patients broadly screened for biomarkers and given the opportunity for multiple possible interventions. And these ideas fit firmly within this concept of a platform trial, a master protocol within which interventions can be tested, dropped, if not performing, and new ones introduced. This is exactly what the recovery trial is. Meanwhile, data-enabled trials have emerged, so making use of the opportunities of data, and in particular electronic patient records and administrative data, to identify cohorts, to enroll patients, to gather data, and in particular outcome data. IoT here is Internet of Things, which is sensors, so ways that data can be easily gathered. We're currently running a trial using wound photography and a machine learning algorithm to try and diagnose wound infection in patients at home. And one step further then is the master observational trial, a prospective cohort study with platform trial embedded using data-enabled approaches to determine diagnostic, treatment and outcome data. This is an example from Cell, which was precision medicine based in cancer. Let me take you one step Further, to what extent now do we actually need an active control group? Do we have sufficient data within the system to determine how an active treatment group compares to their synthetic counterfactual? Their synthetic individual who simply lives within the computer. And that's a question mark at the end of that sentence. And so finally we arrive at the interconnected health data ecosystem with embedded platform protocols. So this is my utopian future where health data and platform-based research are actually synonymous with the clinical practice in which we all work. So when is a cohort study better than an RCT? Well, observational and interventional approaches to research are complementary, and we are now integrating both of them to causally understand disease. The cohort studies clearly have a large role in understanding real-world data, as COVID Surge and Global Surge and many other studies of their ilk have demonstrated. Classical RCTs in many, read most settings, will be replaced by data-enabled platform trials allowing interventions to be brought in and out. And so modern trial designs will actually incorporate real-world data. So many people involved in the work that I'm involved in. This was the Global Surge group when we last met in person. And this is my own group in the Surgical Informatics group in Edinburgh University. Thank you very much.